Hi, good morning, everyone. Welcome to our Accenture office. And thank you so much for taking time out of your busy schedules to be with us here, either in person or online. My name is Natasha Sunderji. I am the Global Health and Nutrition Lead for a unique group within Accenture called Accenture Development Partnerships, essentially Accenture's social impact practice. I'm so thrilled to be able to be our host today for what I'm sure is going to be a very interesting conversation. Now, today's gathering is a little unique in that nearly half of you aren't members actually of the Bay Area Global Health Alliance. So with that in mind, we wanted to take a couple minutes to walk you through what is the Alliance and help you to better understand who we are and what we do. So the Alliance is a membership organization. It serves as a central network hub with more than 85 different members across different sectors. We serve as a neutral convener, a communicator, a connector, a broker of multi-sector collaborations that engage not just the global health traditional actors, but also the tech sector. Their theory of change is quite simple. It's the idea that collaboration across multiple sectors, expertise, and geographies is required and necessary to solve today's most complex global health challenges. We believe in the catalytic power of shared knowledge and cross-sector collaboration, and that together we can shift what's possible and achieve better, more sustainable health outcomes for all. Now, before we move forward, I want to give a big thank you to one of our catalytic founding members, Gilead Sciences, for making this entire exploration possible. What began as exploring the intersection of implementation science and health equity has really evolved into insights for action. From the beginning, the project has been intended to identify opportunities and enable actionable next steps. I ask you to keep this in mind as we get into our sessions, as we talk through our insights panel and participate in various breakout sessions later today. I also want to take a moment to introduce the Alliance board members, team members, working groups who are here today. If you're in the room, please feel free to stand up so folks can identify you. For those of you who are on Zoom, feel free to wave. Fantastic. As many of you are not members of the Alliance today, take note of some of the folks who waved, who stood up. Feel free to reach out to them at any point today if you have any questions around the Alliance and what we do. All right, a few housekeeping rules. Please make sure that you're introducing yourselves to your table mates, to your various breakout groups. Networking is a really important part of what we want to achieve through the Alliance and through today's discussion. For those of you who are on Zoom, please feel free to chat with one another, introduce yourselves in the chat window. We want to make sure that you have a similar experience to those of us that are fortunate enough to be here in person. But if you are on Zoom, I would ask that you please stay on mute so that others can hear what's going on either in the room or online. We do want your input, but you will notice when Colin shares the agenda that we are very pressed for time. So feel free to share your questions, your inputs via chat, follow the QR code on the next slide so that we can make sure that we are capturing your insights, your questions, and sharing them back with you. For those in the room, another housekeeping rule, food will be on the side of the room, and most importantly, the restrooms can be found just down this straight hall here. Now, some of you will depart after the first hour. About 2/3 of you will stay for the virtual and the in-person small group breakouts, during which you should have a lot more time to share your inputs and get into a discussion. And Colin will share a lot more about that in a couple of minutes. We will be monitoring the chat. If we do have time for QA, we will try to take 1 or 2 questions from the audience after each of the insights panel. Like I said, if we don't, we will capture those questions. We will share them via email or in our follow-up November 3rd session if possible. The Google form that we were talking about, you can access it through that QR code. And without further ado, let me turn the mic over to our 3 working group members for the initiative. The brilliant Colin Boyle, our chair of the Bay Area Global Health Alliance Board of Directors and a lecturer at UC Berkeley Haas School of Business. And actually, I'll leave it to you, Colin, to introduce your fellow members.
From Gilead, please come on up. Yeah, and then we also have Aditi who missed her flight, or actually, sorry, didn't miss her flight, had 2 flights canceled on her, but would be here in person, 2 flights, but is able to join us via Zoom. Thank you, Aditi. And what we're going to do is talk a little bit about the scope of the project. But before I do that, just thank you to Natasha and thank you to Accenture for hosting us today here in this room. It's a really generous, lovely room, lovely view, lovely opportunity to connect in a comfortable setting with people here. And again, thank you to those of you who made it here, and thank you to those of you who made it to Zoom. So with that, I'm going to turn it over to Tu to talk a little bit about the scope of the initiative that we're here to discuss today, and talk a little bit about what we're going to do over the course of the day as well. So Tu, over to you.
Thank you, Colin, and thank you everyone for being able to join us today. For those who were Bay Area Global Health Alliance members, you may have remembered me from the annual meeting where I was your host of Global Health Family Feud. If we can get a slide up to kind of refresh that game show experience. We opened that annual meeting and gave a teaser about this work with Family Feud because we really wanted to show that across sectors, we're often talking about the same things, but we're using different languages. So during Family Feud, we sort of play acted having a team that had members from the academic sector, private sector, and NGO. And I asked the question, give me a description of unmet need. And, people buzzed in and we got these 3 answers, from the academic sector, we wrote down clinical burden of disease, and NGOs wrote down community needs and preferences. And actually from the private sector, myself at Gilead, we often think about unmet need as, underserved markets or excess demand. And so we did this little skit to really show that across sectors, and especially for this concept of unmet need, we're talking about the same things, but different sectors are using different languages. And so at the Bay Area Global Health Alliance, which is bringing us together today, we believe that many of the challenges of healthcare are familiar to other sectors, but we speak about them in siloed terminology, which really limits the lessons we're sharing and limits collaboration. So today is motivated by the problem statement, and I want to get this right, so I'm going to read off of it. We're motivated by the problem that too often promising health interventions do not reach the world's most vulnerable communities, or they're not effectively designed and adapted to community needs and constraints. This results in significant unmet needs and growing health inequities. So today, I think we're all here to close the gap and specifically use the lens of implementation science so that we're using the right methods, really thinking about these strategies that will facilitate the uptake of practices, things we know that work, into more regular use, and to actually achieve that impact that we're all after. So with that, just wanted to kind of give an overview of, there's a lot of different sectors in this room. I really hope that today is where we're connecting and kind of playing Family Feud ourselves. I won't be your Steve Harvey, but through all of this, I hope you guys get a sense of this is a good time to connect and really interrogate, and hopefully get some points on the board of how we're speaking the same language. But I want to now throw it over to Aditi to tell us more about how she's led this work with the team.
Thanks, Drew. Hi, everyone. I hope you can all hear me all right. My name is Aditi Rao, and I'm supporting this project as a Global Health Fellow at the Alliance. So in my experience in global health research and practice, I've so often seen that really a disconnect between needs that are identified and prioritized by researchers and industry partners, and those that are felt most deeply by the communities that we're seeking to serve. And so very often, interventions that we design to work in low resource settings, they fail to consider realities of the health system, available resources and infrastructure, financial viability, perceived value of the intervention amongst the communities that we're hoping to serve. And all of these are very often only really considered after the fact, which prevent us from achieving effective adoption and sustainability. And so today's discussion with over 100 of you registered from different sectors and geographies, is building on the work that we've done so far. So beginning in March, earlier this year, we conducted a rapid review of published and grey literature, exploring concepts of implementation science and research in healthcare, health equity, multi-sectoral partnerships and collaborations, really to identify gaps that exist. And this was then followed by interviews and small group discussions with individuals, again, from across sectors. And these interviews actually were with many of our Insights panelists today, and also many of you in the audience today. So thank you all for your time. And all of these interviews were really, really fascinating. And we have attempted to summarize and share the top 5 insights from the literature review and the interviews in the pre-read, which Abby, my colleague, has previously shared with all of you, I think, by email. But you can also find a link to the pre-read in the calendar invite for today, in case you haven't gotten to it yet. So really today we're hoping to dig deep and uncover additional lessons from academia, nonprofit, NGOs, the private sector, and the public sector to improve multi-sectoral collaboration, ensuring that healthcare solutions are well-designed, implemented, and scaled. And we're using HIV and PPH as examples in the work that we've been doing. This project, as Stu and Colin and Natasha mentioned, is led by the Bay Area Global Health Alliance as a multi-sector network and a trusted neutral convener. And our goal today is to translate our learnings into actionable recommendations. Thank you, everyone. Colin, back to you.
Thank you, Aditi. Really appreciate it. And thank you for providing a bit of an overview of the process we've gone through. This is an interesting collection of people here in the room. We all work in global health, but in different ways. And when you work in global health, you learn that it's hard to scale things up, and it's hard to do so equitably. And yet, it's possible. And I think we're all here also because we believe that the rigorous application of data and analysis and skills can remove barriers to uptake and can remove barriers that prevent us from getting equitable results. In the academy, that process of applying rigorous methodologies and data to solve problems and enable patients to seek care and enable health systems to deliver care is called implementation science. Anyone want to offer another definition of what that word that might be in the private sector? You might call it marketing, brand management. And probably half of the people in the room are like, what's implementation science? And the other half are thinking, what's brand management? And therein lies the opportunity, because we have an opportunity to learn from each other across sectors. The greatest successes over the last 4 decades in global health have come when the sectors have worked together and brought complementary skills to bear on big problems. We're blessed to have Eric Gooseby here, PEPFAR representative, HIV, the incredible success we've had in HIV. Well, that was industry innovating on new drugs. It was a massively run, successful government program. It was nonprofits working across sectors. It was CHI, renegotiating pricing. All of that worked. 25 million lives saved. Malaria, again, drug innovation, government programs like PMI, nonprofits like Malaria No More, and many others working together. So that's all possible if we talk to each other and coordinate. And so that's the kind of stuff we want to get on the table here today, because we know there are barriers to the sectors working together that complicate the issue. So here's what we're going to do today to try to get at that. So we'll have a series of lightning talks. You can't see it on the screen here because of the Zoom thing, but a series of lightning talks, 7 fantastic speakers who have worked on some of the issues we're alluding to here and have lessons to share about their experiences. That's great fodder, great context for us to go into the breakouts that will follow starting at 9:45. We will have breakouts involving the people in the room here. We'll actually go upstairs. And the people on Zoom will also be broken out into groups, deliberately constructed in a cross-sectoral way to get people to talk to each other across sectors and see what we can learn from each other. As you can see, there's a series of breaks interspersed here as well, where people will have a chance to network both on the Zoom and in person. And then we'll conclude at 11:10. Well, the concluding stage of the day, we'll start at 11:10 with a bunch of readouts from those breakout groups, talking about the major insights that people took from the conversation. So that's what we want to do today. If I can get you guys to move the slide forward one more slide. So just in terms of setting the tone for that. So I mentioned before that the Alliance is deliberately constructed as a cross-sectoral network. And so if any of you are interested in learning more about the Alliance, joining the Alliance, being part of our community, grab me, grab any of the other board members. I do want to, that's the advertisement piece. I'll put that there and then move it aside. Or sorry, if it's not advertising, it's behavior change communication. Sorry, let me just kind of get that to the side. But what is the kind of nature of the discussion we want to have here? We want to set the tone around a few things. First of all, the breakouts and those discussions will be Chatham House rules. So be frank. One of the things we heard in the interviews was that it's really hard for people to be honest with each other in partnerships because, you know, sometimes stuff doesn't work and you really can't tell the funders that quite so loudly, right? And so you have to be kind of cautious and talk about the things that are going well and maybe not so much the things that are not going well. But there are lessons, lots of lessons, and the things that aren't going well that we can learn from. So Chatham's House rules, safe space, be candid, trust the other people there. Again, there are barriers that prevent the sectors from working together. Those barriers don't have to exist in this discussion. We can allow people to be candid with each other, try to build some trust and respect each other, even though you're coming at these problems perhaps from a different sectoral perspective. We want to try to be action oriented. I think, you know, one of the things we hope will come out of this are some very practical next steps that we can start to mobilize. We have a follow-up meeting in a week to sort of talk about this discussion debrief and sort of think about how we translate this into action. So be pragmatic in what you're suggesting. Listen and be collaborative. We want creativity, kind of multi-directional learning to come out of this. So be open to different views and ask, you know, interesting questions, challenging questions of other people to learn why they think certain things might be a good idea. And we've set this up in a way where we want to include everybody. And so as you'll see in the breakouts, we're being deliberate and intentional about how we're trying to facilitate these discussions so that we can get everybody's view on the table and not have it be dominated by just a couple of people. Okay, so that's the tone. With that, what I'd like to do is invite up our first lightning talk participants. And actually, first of all, Krista Donaldson, who is here. Thank you, Krista. I didn't see you. Who is a member of our board, recent new member of board, but definitely winning the prize for best new board member. Not to sort of set a standard for others on the board to sort of compete with, but if you want to compete with Krista, you're welcome to try. But Krista will facilitate the lightning talks.
Hi, everyone. All right. I'm going to invite Dilys Walker up. I'm going to move right here so that I'm in the camera. Thank you, Natasha. And then joining us remotely from Bengaluru is Rishika. There you are. Thank you. And I know you all had homework. Did everyone read it? Don't worry. If not, I'm not going to call on you, but we are going to reference the 5 insights, and I'll give a brief summary as we get our lightning talks going with our esteemed colleagues. But to kick us off, first of all, thank you for joining us, both of you, remotely and in person. So with Dilys and Rishika, we're going to talk about insights 1, which is around partnerships and the need to build them, and number 4, which is how we define success and the importance of trust and transparency. And I also want to say thank you both for participating in the interviews as part of this research as well. So Dilys, we'll start with you. You're an expert in maternal and child health, a longtime advocate and leader in our field. And you focus on improving the quality of care delivered to women, mothers, and newborns. And I know you work closely with policymakers as well in reviewing evidence and developing guidelines. And most recently, you've been supporting efforts around developing more equitable global partnerships, which is one of the things we're talking about today. So my question for you to kick you off is, what conversations do we need to be having from the very beginning of a collaboration if we want to be effective and well coordinated? If you can answer that, you'll solve all of our problems.
Yeah, you start with the hardest at the beginning. But first of all, I just want to say, has it ever happened to anyone that the photo they submit is the same outfit they're wearing at the event? Like, I'm like, okay, I have to remember never to wear this again if that's the photo. I didn't even think about it. Anyway, so thank you for inviting me to speak and share some of this work. And I think the first thing that I want to say is this isn't my work. The work that I want to sort of mention is work that we launched probably about 1.5 years ago to start addressing some of our partnership and the equity or lack of equity in them. And specifically, I will acknowledge Joe Novotny, who's in the room, and Eric Gooseby, who are parts of this and have been real contributors. But this is a work of over 50 people, half of whom came from our global partnership. Okay. And so I think, when you think, oh, this is an academician, she's going to talk about partnerships. What does this mean for me? But I think that some of the insights, and particularly maybe about the process and what you have to go through to get there, is valuable, whether you're trying to implement a new tool, you're got a new program, or whatever the drug is. But I think from the insights that we have, I think that they would be valuable to anybody. So when we set out, we recognized, this was a year and a half ago, there were lots of commentaries and editorials about decolonizing global health and improving equity. And what a group of us here and in our African partners were thinking, well, what does that mean? Like, who is deciding what that means and what the agenda should be? So we were able to establish this, large working group. It started with a survey to all the partners we had. And one of the main insights that came out of that, looking at who values what from partnerships. What is industry getting out of a partnership? What am I as an academic getting out of a partnership? What is my colleague in Kenya who is, works 5 different jobs getting out of a partnership with us? So we wanted to better understand who is getting what out of those partnerships and what is important. And if I leave you with nothing, one of the insights that was most kind of striking to me was that what our partners value more than anything is respect and communication. And having to sort of address that and take a long, hard look at that, like, how did that come up? Because that's really all about relationships. So once we were able to sort of set the stage and an environment in which we were willing to listen and hear, suddenly sort of everything started flowing. And the survey went on to an in-person meeting where in Africa, where we broke into these working groups and we established 5 domains of action. And these are things that we collectively agreed were important to work on. And those domains were, first one, relationship building, not surprising. Second one was around education, training, and mentorship. So in any of these relationships, those opportunities have to be bi-directional. It's not one side learning from the other, and it's kind of acknowledging and recognize that everybody has learning opportunities and teaching opportunities on all sides of this. The third one was around, in the academic world, authorship and dissemination is always very important. Many academicians' advancement depends on it, and that's very skewed. So addressing how and who gets recognition for what types of involvement is something we all are going to have to readdress and understand and find sort of probably new measures. Another one was around ethics and community involvement. And I think this gets a lot to who is setting the agenda where of what we're doing, and making sure that we are involving all those people that are really the ones that are going to be benefiting or harming from whatever we're doing. And then finally, and I think this is where Joe and his team comes in, he runs the International Research Service offices, I think that's what IRSO is equity in financial management and administration. And yes, we went there, and yes, there was lots that we have to address. And I think, to kind of finish up this question, what was most kind of eye-awakening was, in each of these domains, there are long, hard problems, things that are going to take a long time to really address, but there are also some really fast wins. And there are some things that you can do that we have been doing, and we can get into those, that really start showing that we're all working in the same direction.
Thanks, Dilson. I'm going to return to you after we talk to Ruchika to talk more about pitfalls and what we can learn from this. So Ruchika, I'm going to turn to you. I'm a big fan of her and their work. So she is, you manage program delivery and execution across Africa for Project Last Mile. And if you read her bio, it's 17 countries. And this is a unique public-private partnership between Coca-Cola Foundation and international actors. And I think many of us who have been in global health for a long time, we were always like, Coke can deliver sodas anywhere in the world. Why are we not delivering medicines and other supplies? And Project Last Mile is addressing that. So, but it's not just that. It's logistics, it's management, it's distribution, it's a number of things to ensure that the goods are in the clinics that need them. So back to you, Rishika. You have years of experience with partnerships and business development, and I know you've worked on a range of projects ranging from pilot phase all the way through national scale up, which is what we're here talking about today. How do we ensure that potential solutions reach the people who need them? So my question for you is, from your work at Project Last Mile, how can we better engage and leverage private partners like Coca-Cola? And what are the pitfalls that we should all be aware of?
Thank you for the question, and thank you for the great introduction. You've already introduced the partnership, so I can skip over that. No, so I think in terms of how to best leverage private sector partners, and just speaking from the experience of Project Last Mile, as you introduced, Project Last Mile itself as a partnership, I think we've had a lot of learnings just in terms of how we've ended up structuring the partnership, how the partnership has evolved over time in terms of what are the best ways to engage the private sector and then apply the best of what the private sector has to offer to supplement what the existing public sector and partners on the ground are doing. I think one of the biggest learnings we had that has led to the way the partnership has evolved over time is really understanding how we can evolve what we offer to the needs on the ground and learn to be demand driven in terms of what the Ministry of Health or the government or local partners are really asking for and what the gaps are in country. And I think exactly as you said, part of how this partnership initially was conceived was to answer that question, that if you can find a nice cold Coca-Cola almost anywhere in Africa, why not a life-saving medicine? And initially, I think the answer was to look at, okay, can we just take a Coke truck, put some medicines on it and distribute them? And that was a lot of the questions I think initially that were being asked were, can you look at just leveraging the private sector infrastructure, the hard assets, which is I think what sometimes first comes to mind when we look at private sector engagement or partnerships with the private sector. And very early days, I think we realized that offering anything like that would never really enable us to have a scalable solution with the Ministry of Health. That would always be reliant in terms of what are the hard resources the private sector could offer, as well as be tied to quite a lot of dependencies in terms of how profit flows were doing in a certain quarter and whether resources could still be offered, for example. And having taken all of that into account, the partnership evolved over time to really look at, let's move away from just the hard assets and look at what we're hearing from partners on the ground is what they're lacking a little bit is also some of the soft side of things, the understanding of what are the best practices, the tools, the ways that the private sector or a company like the Coca-Cola system would approach, for example, a last mile distribution challenge and evolve what we offer. So it's really looking at bringing in private sector best practices. So subject matter experts who have 30 years of experience working with Coke distribution challenges, for example, and embedding them within the Ministry of Health or a different government agency, and looking at applying that kind of expertise to support the Ministry of Health, and then looking at how they can scale up or solve a particular challenge. And I think we found over time that being able to deploy that kind of expertise, that kind of integrated subject matter expertise that's working hand in hand with our government partners or local partners on the ground has been a much more effective partnership model that has allowed us to listen, be demand driven to their needs, as well as evolve the types of expertise that we bring in.
Thank you. We are about out of time, but I would like to ask you both a rapid fire question, which is, what pitfalls should organizations who are part of the Alliance and not, should they be thinking about in partnerships like this?
Rapid, I'll be
Rapid, thank you.
really quick. I think you really need to want equity in your partnerships. If you don't go into it really understanding what that is and genuinely wanting it, and genuinely being willing to dive into difficult and awkward conversations, because that's the only way you're going to move forward. And you may all be thinking your partnerships and relationships are great, like we did. And I can assure you they probably are not.
Great. Rishika, do you have anything to add? Rapid fire?
Rapid fire, I think one of the pitfalls we initially had was focusing on pilots and scale. And we've seen a lot of organizations that forget about that middle part of it. And I think focusing on ensuring that you have the foundations before you try and get to scale is a key one. So just focusing on that middle piece between pilots and scale.
Wonderful. And I'm a big fan of designing for scale from the beginning. So thank you. All right. Thank you to both of our speakers. This is lightning, so we're going to keep moving very quickly. Thank you, Dilys and Rushika. All right. I'm going to invite Alex to come up. And so Alex Asimwe and Claudia Marr, who's going to join us remotely. Welcome. We'll get you a microphone. There we go. I'm going to tee us up a little bit here. Partnerships are hard. I feel like Dilys, you really underlined that beautifully. Thank you. We are often too hesitant to discuss differences and failures. So now getting back at some of Colin's comments, but there are ways of reimagining partnerships and revisiting how we define success. So for example, if we prioritize trust building and transparency from the beginning, and I know that's easy to say and hard to do, and we're going to dig into that a little bit today. And when we get into our small groups, we're going to be talking about this too. So shifting to our next talk, I'd like to welcome Claudia and Alex, who will help us unpack how technology and digital solutions create new efficiencies and allow us to think bigger. And really, how do we think about equity when we're developing these tools and deploying them? So we'll start with Claudia. Hi, Claudia. You're on the screen.
Hello.
You lead strategic health partnerships at Google's Search Social Impact Partnerships team, and you've spent much of your career making it easier for people to access care across health systems, governments, academic systems, and tech. So I feel like you've hit all the sectors there. The other thing to know about Claudia is that she started her career as a nurse. So she has firsthand experience as well as a clinician. So first of all, thank you too for participating in this work, and Alex Gilead for supporting it as well. Claudia, one of the things we heard in an interview was there should be no design or planning of projects in global health without a tech person in the room. They're able to put forward ideas we don't otherwise think about. So from where you sit at Google, how can the global health community better leverage technology?
Well, thank you. It's funny because someone recently asked me the question of why do you and why does Google attend conferences like the World Health Summit? And I actually just got back from Berlin a few days ago, so I feel this kind of gets to that question in some ways. And my candid response is I think it's a mutually beneficial opportunity to learn from one another about our respective priorities. You know, Google is inherently a global company, and in order to build products that can scale internationally, we need to better understand priorities from global health stakeholders, and that includes NGOs, ministries of health, KOFs, in order for us to then be able to kind of upscale that into the way that we, can develop solutions that are intended to reach people where they are. And so when we think about product development at Google, we think about the user first, and that can be consumers, it can be caregivers, it can be the community writ large. And that's often who is sitting at the table. And that's really beneficial for us to hear firsthand and to then kind of take that back to our product teams to help inform product development. And so when we think about our approach internally to develop solutions, we often have a diversity of perspectives. We'll have a product manager, we'll have engineers, we'll have a policy person, a partnerships person like myself. And all of those viewpoints are really embedded in our structure for how we develop product. And so certainly we would advocate for having someone who understands technology as part of that dialogue for building, global health solutions. But I think equally, if not more important, is having someone who understands the local reality and having, a local engineer. And so when we think about the products that I mentioned in terms of consumer, caregiver, community, one, I think, recent example of that is our Open Health Stack. It's a product that we launched earlier this year in close collaboration with WHO, and it's essentially a suite of open source components that are designed to accelerate the development of interoperable digital health solutions. And so I think where we stand is to be able to develop the kind of the foundation for Android supported apps, the backend infrastructure, and then allow local developers who can sit in front of community health workers, who can understand the challenges inherent in their day-to-day and their workflows, and then kind of build that front end with usability in mind, and creating kind of those interoperability standards and solutions that can create more equity on the local level. And a really kind of great example that resonates for me is Mama's Hub, which is an app that IntelliSoft developed out of Kenya. And so Mama's Hub is an app that community health workers can actually leverage instead of their paper-based handbook, they can use an Android smartphone when they're going from antenatal visit to from patient to patient, and they can record details of their visit on the smartphone and actually facilitate referrals to across facilities. And they can also start sharing information across community health workers with the mother, with clinics, and with family members that can have different access control. So I think it's a good example of how we think globally, but then we build the infrastructure that can be adapted to local solutions and kind of creating equity in terms of those locally adapted solutions and apps.
Thank you. I want to pull on this theme too of one of Google's core missions, which is making information accessible to everyone around the world. So if I'm an organization and I feel like I need help from tech industry or Google to get information out, make it accessible, what do you recommend? How do we leverage Google? How do we leverage other tech companies to do this? How do we make it usable and accessible? How do we make our work? How do we get it out there?
So I think, I come from the search world, so I'll kind of speak to our consumer efforts. When we often think about consumer, we think about search. And to put things into context, roughly 3 out of 4 people will turn to the internet when they start looking for health-related information. And we actually receive, hundreds of millions of health-related questions a day on our platform. And so it's a big responsibility, and it's a big part of our mission to try to connect people to high quality, authoritative, and credible information, no matter, where they are across the globe. And I think to do that, my personal belief is that we need to think both globally, but also locally. So I think that sort of transcends both of these questions. And so typically when we think about disseminating health information, we might start in certain countries of focus where there's higher user adoption or engagement, where there's better data availability. There's a number of different factors that might come into play, but ultimately we do view information as a critical determinant of health. I think a number of folks in the room virtually have heard me say this before, but we do mean that. And I think it's that because we want to ensure that information gets into the hands of every potential user across the globe. But there are challenges to doing that effectively, right? And so it depends on our ability to establish really strong partnerships with authoritative and credible content partners that can actually facilitate the scale of that information. So one of the features that we have on search are called knowledge panels, and they essentially help us to display information on medical conditions, on symptoms, anything ranging from like knee pain to headache to type 2 diabetes. And one of the things that we realized early on is that users need to understand the source of information, and they need to view that source as being credible. And ideally, they need to be able to look for that information in their language of choice. And so we can't take a blanket approach for how we disseminate that information. And that's why, like in the US, we've partnered with the Mayo Clinic. In the UK, we've partnered with NHS. And in India, we're partnering with the Apollo Hospital to display content in both Hindi and in English. So there are nuances for how we do this, both at a global level, but then contextualize that information locally. And I think that nuance is really critical. So now we're trying to do that in collaboration with the World Health Organization to display health condition content and scaling that much more rapidly across nearly 80 countries and 6 languages. And my hope is that we'll see that we can go about that process much more effectively and efficiently without compromising the ability to display authoritative and credible content, both globally and locally, and try to find, more effective paths to get content that's evidence-based into the hands of people in an engaging way.
Great. It's interesting to learn how things happen behind the scenes. Alex, I'm going to turn to you now. Alex is the head of real-world evidence generation and partnerships at Gilead Science, and you lead the transition of scientific discovery to real-world solutions. Your background is in pharmaceuticals and epidemiology, and I'm told you are passionate about the role of technology in supporting more inclusive research and big data analytics. So welcome. My question for you is, what are some of the pitfalls in how we use technology to generate insights to improve patient outcomes? And this could be on unmet user needs, design solutions, et cetera. And so my question is, what may exacerbate inequalities? And how can we better avoid them?
Okay. Again, thanks for allowing me to sit before you for the next few minutes. It's my first month in San Francisco, coming from Europe. When I thought I'd seen everything in Europe about inequality and unmet needs, and then I come to San Francisco, my mind has changed completely. And if you had asked me this question yesterday, I would have I was going to give you a different answer, and I'll tell you why. In Europe, there is an emphasis on private-public partnerships. It's because through partnerships that we can resolve things, because if you have industry on one side and public on the other side, private-public partnership have to work together. Please do go in partnerships for the right reason, not to make money. I think that's really the main pitfall of why some private-public partnerships don't work, especially when it comes to resolving unmet needs and addressing the inequalities. Now, as the title suggests, I'm a real-world evidence person. I love data. I'm a clinical epidemiologist, so everything I'm going to say now is going to be based on the data. So with digital solutions, you can develop lots of digital tools, but those digital tools will have to be coming from real-world data. And real-world data has to be really good real-world data. Now, if you look at the current infrastructure that we have, and we're talking of real-world data, in Europe and in the US, we have all the real-world data we want. We have all the data from all of you guys when you're in the hospital. That data is made available, which means we can develop very good solutions, digital solutions that can help address some of our unmet needs and improve patient outcomes. But we're global. We are global, right? We don't know anything about Africa. We don't know anything about Asia. I'm not saying that there's no data in those countries, but we don't have an infrastructure that we can access to have that data and develop these digital solutions. So my suggestion would be having some great public-private partnership that focuses on building an infrastructure in Asia, those developing countries, because in Europe and the US, we already have that infrastructure. And people who own those data sources make a lot of money. And therefore, they don't have incentives to go in Africa or Asia or South Africa to actually make that infrastructure available. Now, we can just use what we have, but that means we are going to only be focusing on the developed world. That's the Europe and the US to make those digital solutions. But we are going to be forgetting about all those developing world. So again, silos, industries, we are doing a lot of work, but we cannot do everything by ourselves. Public, you can only do things by yourself, and it's not going to lead to the right solutions. Again, I keep on saying it's through the private-public partnership that can lead to building a big infrastructure in data acquisition and access that then leads to building these magical digital solutions. We can use AI. Now everyone is talking about AI, but you can't use AI. AI is going to be useless unless if you have the right data, right? So again, I just focus on let's get away of having access and building infrastructure on real-world data, patient data that then helps us in developing those solutions. At the moment, we rely on literature in Africa, in Asia, in South America. We rely on literature because it's easier to get literature. But literature is literature. Someone just does a survey and says, this is the incidence rate of people with X, Y, and Z. That's what you have, but it's not reflecting on what's happening in the real world. Now, if I wanted to know the incidence rate or prevalence rate of someone in the US, it's very simple. We can do it. In Europe, we are getting funding from European Commission to set up what we call European Health Data Space. And the reason for that is because we are thinking of how can we minimize the inequalities? How would we identify the unmet needs? So if we can imagine, we can link every person in Europe, including UK, by the way. If we can link all of them and we have access to their data, of course, you have to control it. Then we can develop all these digital solutions, right? So to me, my vision is to see, I can't wait to see that time whereby I want to see what is the incidence rate, what are the unmet needs in Europe, in the US, Africa, Asia, and South America, all being done quickly with a click of button. That's a wishful thinking, but that's really what I wish to say. Again, as an epidemiologist, that's what I think should be happening in order for us to address these unmet needs and reduce inequality.
Thank you. I think even the non-epidemiologists would appreciate good data from everywhere. So thank you. Unfortunately, we're out of time with Alex and Claudia. Thank you both for your excellent comments and thoughts. So thank you. Thank you both. We are now going to go to our third. We have 4 what we're calling lightning talks. I'm going to call them lightning panels because we are moving very quickly. We have Amina Tao Sarr in Senegal and Professor Moshe Bila in South Africa. So when Natasha was opening up, she mentioned that a third of our alliance members are tech or digital health focused. And so you met Claudia from Google earlier. We have members from Meta and others. It's an opportunity for us to reflect on the opportunities and limitations of technology and digital platforms. And we started to get into that just now. But for the broader group today, particularly for those of you who aren't members, I think it's also helpful to hear the perspectives of the tech companies. And particularly in understanding where technology and digital health organizations are coming from as they're setting their agendas and their strategies. So we hope to dig into, especially when we go into the small group, digging into things, some of the big challenges like data access and ownership, because that's something that affects us all, especially if we're following Alex's advice and trying to build data systems in all parts of the world. So for our third lightning talk, we have Amina Tao and Professor Moshe Bila. And good afternoon and good evening. So we'll be focusing this talk around Insight 2, which is related to co-creation and securing local buy-in from the beginning of the projects. So Amina Tao, you're director for Senegal and West Africa Hub for PATH. I think everyone here is familiar with PATH. But you currently support and oversee the implementation of programs across the region. And I love the detail about you that you were previously a journalist. And what I know about journalists is you're very good at thinking high level and in detail level. So I hope you'll share both with us today. So I'm going to jump to your question, which is, as local implementers and project experts, what steps should all partners be taking from the beginning of a project to set the right tone and truly co-create?
Yes. Oh, thank you. Thank you for your question, and good morning, good evening, good afternoon, everyone. And I apologize, of course, for my English, which is my maybe third language. Just to say that I think from the beginning, I think we need to really build trust. Trust is not something that is going to happen just by miracle. We need to create the space that will provide the trust that needs to happen between a diversity of stakeholders to move on the same direction. I am saying this from a current project that we are implementing in Senegal, where we are trying to push the agenda of having self-care as integral part of healthcare. And in doing this work, we bring together more than 40 organizations, from private to public, to patients associations, women's group, young people's group. And we need to acknowledge that each of these groups have different perspectives and different agendas. And the most important thing, and maybe the most challenging thing, is to build enough trust for everybody to put together an agenda that will respond to everybody's need. It's not always something easy. Above all, we know that by doing this type of work and by bringing together this diversity of stakeholders, we are also bringing some ambitions together. We are seeing people how the fears of losing power, like between the health practitioners and people and the communities that they are serving, and sometimes the lack of trust that you could see between the public and the private sector. And I strongly believe that our health system, above all in the low and middle income countries, we can't fund 100% of our health system. So the role of the private sector is very important and instrumental to fund our work. But to do that, we need to know each other. We need to trust more and more each other, and we need to create the space for those entities to talk together and see the common interest. And the most important in this type of conversation, in my point of view, is just how we put people in the center of the conversation. We are doing this for people. We are doing this for our communities. We are doing this to advance people's health outcomes. And if we have that in common, everything that we will be discussing will be conducive to achieving this goal in strengthening our health system, giving the tools that the people need to take care of their health and be part of the management of their health. And it's difficult. It takes time. It takes iteration of discussion, interaction. It takes also a kind of high-level buy-in. What we've done in Senegal is really bring the Ministry of Health and have someone at high level being the driver of those conversations to show the interest of our government in this conversation and build that trust that because we are here to support this conversation, we will be here to implement also some of the solutions that will come from the conversation you are having for self-care. I think that applies in many things that we are doing. And in doing also this type of work, we need to acknowledge that it doesn't matter who we are. It's not about past. It's not about the Ministry of Health. It's not about all the private sector players that are involved in these conversations. It is not just about associations. It is about people. And as long as we have that as our red line in our conversations, the solutions will come. The private sector is not just the private sector in our health sector. It is beyond that. There are so many other private companies that would like to do things for health, have the money, and don't know how to enter into that space and bring those resources. I heard just previously about, yes, we are not here to make money. For me, it's not a problem to make money. The problem is how we make usefully money. Being a private sector means that we have also some goals, business to run. But if we put this business in the at the service of health, at the service of public gain and benefits, I think it is very, very valuable. And we need to trust the private sector to be able to play that role. And the private sector needs, of course, to trust also the public sector that we are able to work together and make meaningful progress in our respective countries. This is the kind of insight I wanted to bring on the table. Private sector is important as well as the public sector. And most importantly, why we are together is what we need to understand and work towards achieving the goals that we set together. This doesn't mean that it will happen after 1, 2, 3 encounters. It doesn't mean that we want to fail. There are lots of private and public partnership experiences that didn't work, but there are many others that worked. And failing is learning, and being genuine, and being trustworthy and walk the talk is very important in this conversation about how we connect all those dots. And this is for me an appeal. Maybe the last insight I want to put it to, yes, dare come and work with us as the public. If I say, we can create the world that we want if we just to trust each other in our exchanges. And trusting each other is not only just trusting people on their goodwill, it is also trusting the process that we put in place, strengthening the process we put in place, and being accountable for the investment and the commitment and the work we are doing. And accountability for me is not just towards the donor, it is also accountable to the communities and the people that we are working with and with which we are co-creating the health system we would like to see in our countries.
Thank you. And yes, I hope we'll be talking more about connecting the dots and bringing alignment to achieve that. Thank you. Professor Mushabila, you are Professor of Public Health and the Deputy Vice Chancellor for Research and University at the University of KwaZulu-Natal in South Africa. You have years of experience working in partnerships across geographies. I know you're currently focused on implementation and evaluation of healthcare programs that improve access, quality, and equity in sub-Saharan Africa. So given all this experience and your perspective as an academic and public health practitioner, could you please share with us examples of collaborations with global partnerships and specifically what's worked well and what's been challenging?
Thanks, Krista. And yes, to all the things that Aminata just said, especially putting people in the center. I think from my experience, I've got a very different experience of these partnerships now later on in my career. And I'm not an old man, just for the record. Compared to earlier on in my career, I think earlier on in my career, I was hot-headed and I always negotiated very hard whenever I got into partnerships. I didn't have many options. And I think this is a lesson that we can take to say, when you are forming partnerships with professionals that are still young and early in their career, they don't have many options. They're a little bit cornered. You have to be more gentle and much more supportive. And so I worked on a program that wanted to tell me what to do for our clinics and for our patients. And I did not agree because it was to the detriment of our patients to a point where I refused funding from them. At some point, I must tell you that I spent 5 years in my career with a personal policy that I will not take any funding from the US because of experiences that I had. And I can mention that it was with PEPFAR and the way it was being managed. And I came out of that experience with a very negative experience of the PEPFAR program, and I decided to go and get funding from elsewhere. So I was using a lot of UK funding, European funding for many years, until someone convinced me to reconsider US funding. And sort of later on in my career, when the likes of Eric Gusby were running things were very different. And kudos to him and the work that they've done with the team. For me, I then realized that you can still actually work with PEPFAR, because I went into NIH and eventually back into PEPFAR and kicking and screaming, but then my experience was very different to what I experienced early in my career. And the biggest difference was not so much the fact that the rules have changed. It was the fact that the nature of the partnerships have changed. The partnerships that I had later in my career were much more supportive, much more considerate, much more attentive to detail and accommodating. And the team that I worked with essentially made me realize that you can stay with the same funding program, but the partners becomes the agents that help you to navigate and can help you to have a very positive experience that can benefit the community that you want to serve in the way that you'd like to serve. And I say that, Krista, just to point out that my experience is that these partnerships are about equity, and equity is about power. And people are constantly negotiating power, and they come with levers of power that they use to negotiate these partnerships, including money, including papers, including skills, data, products. And when we are in the global south, it becomes very difficult to negotiate back. And at an early stage in my career, it was much more difficult to negotiate, which is why I was hot-headed. But now it's no longer a problem because then I have the credibility, the resources. In fact, now if you're going to partner with me, I want to chip in as well. I want to put skin in the game with the resources, the little resources that I have, because I know that I'm negotiating power constantly. So a lesson here for me would be that in these partnerships, we've got to be careful not to misuse the assets that we have to make sure that we to end up using them as reinforcers of superiority and supremacy in that negotiation of power. We have to be intentional in distributing and sharing. So I want to say that this whole conversation we are having, it's not simply about whether equity is about fairness or fair distribution. It's really also about equity being about leverage of the assets that one brings, leverage of power that one has, and we are constantly negotiating, and we've got to be careful with it. I'll stop there.
Thank you very much and for your transparency. I know we're out of time, but Professor Mushabila, I do want to follow up because you talked about the hot-headedness, and I think many of us starting our career certainly felt that way, but you have been doing some work with healthcare students in their final years, and I was hoping maybe you could briefly speak to that, given your comments.
Yeah, so I think, Krista, the lessons we've learned also is that we train people. I'm a medical doctor. We train health professionals, and they come into the field of global health. They now bring in the skill sets that they bring from their professional groups, but they have not been taught to work together. And because they've not been taught to work in teams, they also don't know how to negotiate relationships, and they don't know how to negotiate partnerships. And so, you then begin to think that your asset is what you bring as an individual to the team, and that's what matters, which creates a contestation of power about, oh, I'm superior. I'm a doctor, I'm superior than the nurse. So these hierarchies begin to disrupt the way we provide healthcare. So we then decided to work with a UCSF, Eric Goosby, Mike Reed, and PEPFAR-funded program, miraculously, that we used to train people in interprofessional education, where we say, yes, get the skills from the depth of skills from your professional group, but really the delivery of it to benefit patients is going to be when you do it together. And when you do it together, don't focus on who's better or who's superior. Focus on the need of the patients in front of you. Open the circle, put the patient in the center, as Aminatu was saying, and then focus on the care that you provide to that patient. And that's the training program that we did. It's about interprofessional education, the values of which apply to relationships as well, because it is about communication, it is about respect, it is about ethics, and all of those values become really important in the way that we engage with each other. These things can be taught, can be practiced, can be encouraged. And if we do that, and we all do that, we will then be able to share the assets that we bring, be it money, be it skills, be it products, be it data. We can share all of those assets for the benefit of the people that we purport to serve. Over.
Wonderful. Thank you both so much. And I think all of our speakers too, you're getting fan chats down below on Zoom. So thank you both. And I hope you have a chance to read it. So thank you both. I'm trying to clap here. Thank you. Okay, we are at our final lightning talk. Sunil Solomon, and he is joining us from Baltimore. During our interview, Sunil's example was very relevant around our fifth key insight, which is around delivering effective care to the most vulnerable. But how do we do that? What business models do we need? What are examples? Where's the sector tried things and they haven't worked? So Sunil, welcome. You are a professor of medicine and epidemiology at Johns Hopkins. Your research focuses primarily on epidemiology, prevention, clinical management, and access to care for HIV and viral hepatitis among vulnerable populations, including people who inject drugs and men who have sex with men. So we have heard from many of our interviewees. Oh, I like your dog in the background. That there is a lack of examples of business models that balance profit for partners with impact for communities, particularly within the bounds of local structures and resources, which we've also been talking about today. So from your work in the HIV space, can you share an example of a model that has worked? And then we have a follow-on question, which is in what way, so it worked, but in a way that supported not just the project goals, but the partners' individual goals. And thanks.
Thank you, Krista, for the opportunity for both me and my pup to join. We were looking forward. He's been looking forward to this for quite some time. So I think my philosophy has always been like, if we want to solve any problem, we have to answer the hard questions, and not the easy questions. Because when I went back to India in 2004 after doing my master's in the US, I think majority of HIV in India is like a heterosexually driven epidemic. So most of the focus was on sexual transmission. But then I found that people who inject drugs and men who have sex with men really were falling behind. And so I started my own practice because that's what you had to do. It was the right thing to do at that point in time. So we started this clinic for people who inject drugs. I was in Chennai in South India. But then we realized that this is like a global problem. And then the one thing you realize very quickly in public health is if you want to have impact, you have to partner with the government. Right? Because you can make a huge difference in a small city, but it's only the government that can make an impact across the country. And so in 2012, we actually started a model with the government of India where we were looking at like integrated models, trying to bring in HIV testing, prevention, harm reduction services, sexually transmitted infection services into one roof, and trying to see how does that impact healthcare uptake. And that worked. Like people who showed up at that center were doing well, but it didn't work equally across the world, across India, because we were working in about 16 cities across India. And Delhi, the capital city of India, we actually saw an extremely high incidence, which is higher than what it currently is anywhere in the world among people who inject drugs. And I was wondering what's going on. And I think Moses and Amanda also spoke about the whole person-centric model. And so we spoke to some of the people in the community and we asked them, what's going on? Like, why aren't you, the government provides antiretroviral therapy free of charge. Why aren't you going there? We're providing HIV testing here free of charge. Why aren't you going here? And then immediately, I think the responses that came back from the community were like, great, you're taking care of an infection, but we don't have food. We don't have access to clean toilets. Many of us are homeless in the streets. We don't have a place to shower. So what's the point of giving us HIV testing? What's the point of giving us antiretroviral therapy when we don't have basic necessities of life? Right? And so that's where this whole collaboration started. And so we had some funding from the Elton John AIDS Foundation, and then we worked with Abbott for diagnostics, because I think in any infectious disease, or any disease, infectious or non-communicable, diagnosis is the first step. Unless you can find people who are infected or living with a condition, whether it's diabetes or HIV or viral hepatitis, there's nothing else you can do after that. And so we explored with Abbott as part of Abbott's Pandemic Defense Coalition, can we come up with a person-centric model? So this is actually a partnership between Hopkins, like an NGO within India, multiple community networks of people who inject drugs in New Delhi, the Delhi State AIDS Control Society, and each person is giving something into the model. For example, Abbott is giving us all the diagnostics we need, and they also gave us some funding to put up toilets and provide food, right? Trying to see is like, so when people come to use these restrooms, while they're waiting for the shower because someone else is in there, can we also improve their access to testing, right? So their products are being used, people are getting what they need, but they're being cross-referred to other services. The Delhi State AIDS Control Society gave us access to the sit-in service program, opioid substitution therapy, and antiretroviral therapy. So then if someone's positive, then they also get linked to antiretroviral therapy. And the whole time, the community is always providing us feedback with like, we like this service, we don't like this service. And we actually started this earlier this month, I think in October. It took us some time to get permissions and get the toilets and the plumbing and everything. But in the past 2 weeks, about 250 people have used this facility. They've used the food services, they've used testing services. And I think that really is the way to look at it, is how do you build these relationships? Because I think we're talking about public-private partnerships. I've heard a lot of people say that, but private is a lot more than just private, right? Because you could have industry, you could have academia, you could have NGOs, which are all private, and each of them bring a different thing to the table. And I think trying to figure out how do you bring all those different components together. And I also think that when we're talking about equity and person-centric models, it needs to be more than us just saying it, but actually doing what the community wants. Like we're saying, oh, it's equity, we're making sure that there's access to this product there. But I think we need to go beyond that and talk to the community and be like, is this the right model for you? Is there something else you need? And how do we actually make it accessible? Because that difference between availability and accessibility is huge when it comes to equity. Like I can make a product available in a country for $20,000 a month, but that's not accessible. So I think that's the thing that we also need to think about. And from an industry and public sector standpoint, I think there's a lot of challenges we've had. And I think the biggest thing is for many of these studies, when you want to move them forward and build these innovative models that are out of the box, you need buy-in from industry and other partners who have the funds and the products, but sometimes we are restricted and we end up doing the science we can do versus the science we need to do. And I think that's the big step that we need to solve, because only when we start doing the science we need to do, and I think like Moses also spoke, is that's what's going to get rid of this equity gap and make sure we have access to services for everyone, I guess.
Well, thank you. And thank you for also highlighting that availability does not equal accessibility, and with such a great example from understanding users. And it sounds like also iterating your work based on what you were learning too from the populations you were serving. Unfortunately, we are out of time. Sunil, I feel like we could continue to talk with you and your dog, but we are out of time. I know there's questions. We hope to have a Q&A actually, but we want to move into small groups. So if you could please, let's first recognize Sunil. Thank you. And we do have a QR code, and I don't know if it's possible, Abby, to flash it back up. But if you do have questions or comments, please do put them there. And so at this point, too, it's also time for our first hour attendees to drop off. We know you have other things to do, and we're grateful you've been able to join us this evening, this afternoon, or this morning, wherever you are. And just as a reminder, we do have our virtual follow-up session on November 3rd from 8 a.m. to 9:30 a.m. Pacific time. And you can register for that session using the same registration form that you used previously.